אוקיי. סבבה, עכשיו אני לא שומעת אותם. איך אני יודעת אם הם על מיוט? Hello?
Hello, anybody there? Richard, you
Hi.
I am.
How are you? You doing good?
Yep, doing fine.
Okay, I've got a microphone. Can you hear me now?
I can hear you. Sarah will be,
Yeah?
Sarah will be right here.
Excellent. Yeah, we've had you connected for about 5 minutes, so we've been watching you. But so far, you haven't done anything wrong, so it's okay.
I hope my behavior has been acceptable.
It's been good.
Oh,
Yeah, it's been fine.
I need to spice it up then, sorry.
So do you see the class, Jim?
I can't. 1, 2,
Okay.
3, 4, 5, 6, 7 people. And it looks like one with a coat maybe and who's gone.
Yeah, well, there are a few people with coats. It's kind of cold, okay?
Really?
Yeah. So I don't think you ever came to the University of Haifa, did you, Jim?
I don't think so. You know, Sarah and I were talking about that, and I do not remember being at the university. Now, I certainly remember being in town and how beautiful it was up on the hill, looking over the water and down the garden, going down the garden. I remember all of that.
In the City Hall, remember? Going to the meeting at the City Hall?
I do remember City Hall. Yes, almost got in trouble.
In your book, yeah, the book story, right? Well, what I think, hi there, Sarah.
Good morning, Richard. Good
Can
afternoon.
you can see me, yes?
Yes.
Okay, good. And we're going to record this, yes? Okay, good, excellent. All right, good. Well, let me introduce you all. I'm going to introduce the two of you, and then I'm going to ask the students to introduce themselves. Okay, and I'm going to pass the microphone on and we'll just go along, all right? But first, on your right is Jim Gross, and I already just very briefly explained to you that both Jim and Sarah are colleagues of mine, and Jim was the health commissioner of Montgomery County, Ohio, with a population of about 1 million people. He was, I think, very successful in the work that he did. His greatest success, however, was that he got an MPH in the first class that I created an MPH program in Dayton, Ohio. And Jim, I don't know if let's see, anybody in the class, you've been in my office, that giant office, you've seen the pictures of my grandchildren, right? But on the top shelf, did you see this little picture of 3 people with graduation gowns? Well, next time you're in my office, he's one of those 2, me and 2 other people, okay? So I'm very proud of that, Jim, okay? So thank you.
My hair's changed colors a little bit.
A little bit, but that's okay. And Jim was here in Israel, and I'm going to ask him to tell us, maybe you can tell us the book story before you start. But first, let me introduce Sara. Okay, and this is Sara Paton, and Sara is a PhD epidemiologist and was doing a postdoc in pharmacology. Is that right?
That's right. And you
She was doing the postdoc in pharmacology, and her mentor contacted me and said, Sarah's interested in epidemiology. And I said, well, that's nice, but I mean, epidemiology and pharmacology only both end in Y, but I'm not sure what they have to do with each other. But Sarah was able to convince us to hire her, and she became our epidemiologist. Half of her time was spent working in the field in the health department, and the other half teaching. And her career has advanced, and I'm very proud to say that she's now the program director for the MPH program. So what we're doing is we're sort of promoting a relationship between our two universities. We've actually had some students from Wright State University in Dayton here on our summer program over the years. And we'll see if this gets us going to do more stuff. So with that, let me pass this on and just introduce yourselves, where you're from, and a little bit, just a minute about what your career has been.
Good afternoon. My name is Lyubov. I'm a medical doctor from Russia. I'm an international student from other program, but today I have a chance to be with you. I'm going to join to this program next academic year.
Okay.
Hi, I'm Becca Goldman from the U.S. I've worked with USAID on international food security and nutrition programs, so my background is very much focused on third world public health.
I'm Rachel. I'm from Canada. My background's in kinesiology, exercise physiology, and then I spent the last year as a physiotherapy assistant, and now I'm here.
Hi, I'm Dafna Raz. I'm from Boston, Massachusetts, and my undergraduate degree is in public health sciences from UMass Amherst. Before coming here, I worked at Boston Children's Hospital and a government agency. I'm here now as well.
Hello, my name is Violeta Levy. I am from Mexico. I am a medical doctor. My background is from working in corporate wellness in a private company. And I'm here.
Hi, I'm Adina. I'm from Toronto, Canada. I did my undergrad in psychology, and I'm very interested in maternal and child health, and I'm here.
Hi, I'm Sara, and I'm from Israel, and my background is in special education.
Hi, I'm Emily O'Connell. I have a bachelor's and a master's in microbiology, and then I worked in a clinical microbiology lab for a little while, and now I'm here.
Hi, I'm Arun from India. I'm a medical doctor as well. Then I moved to France to do master's in neuroscience and aging specialty. Now I'm here.
You have to say that.
Okay, that's the group. Now, Jim, you want to tell them the story about the book or not? Or you just want to get going?
Sure, I'll make it pretty quick. First of all, I've always been very thankful that I was able to visit your country in your city. Had a lot of fine experiences. Dr. Schuster was kind enough during our trip to make sure that we got all around and got to see a lot of different things and had some very interesting discussions. And one of those was with your local government. It was the mayor's office, right, Richard?
Yeah, it was the vice mayor.
The vice mayor, and we had a meeting with them, and it was a very enlightening meeting. And I don't know if it's one of the things they traditionally do, but they were wanting, I believe, to give the book to you, right, Richard? It was a very nice, large book with a lot of illustrations, beautiful pictures in it, all about Haifa. And Richard was kind enough to let me take the book, right, Richard? Or was that it might have been a setup on your part?
No, you were the chief government figure, okay? So you were the most senior person there, and they gave you the book. I didn't count, okay?
That sounds very nice. I still think it was part of the setup. So I was the first one from the group to leave and come back And I was dropped off at the Tony airport by some of our group members. And I had put this large book in my suitcase. And I really didn't remember what I had done with the book or anything, but as I went through security, you all understand your security procedures a lot better than I do, but everything went through the big gizmo that they have there, and they asked me if I had anything in the suitcase that I was taking from the country, and I said no. So when my suitcase shot out the other end, some people began to gather around my suitcase, and before I knew it, there were probably 4 or 5 different individuals, all part of security, around my suitcase. And I think it was about at that part of time that my blood pressure probably began to rise a little bit. And they came over and they kind of took me and brought me over and said, "What is the object that's in my suitcase?" And I said, "I don't have an object in the suitcase." And they said, "Yes." And they showed on the scanner that there was something in there. And to shorten the story on you, they pulled out the book, and they were not very happy with me, thought that I was lying, and I don't know what they thought I was trying to do with the book, but I was chastised and told that if I lied to them again, that I would be put away. And I tried to tell them where I was from and how important of a guy I was. That got me nowhere. I even told them that I knew Richard Schuster, and they said that doesn't make any difference whatsoever. But I was able to escape jail and make it back to the States, but I still think that Dr. Schuster set me up with the book.
Yeah, I'm sure you're really anxious to come back to Israel, Jim, and try it again, right?
I understand. I understand my mugshot is up on all the airports.
Just before you start, my colleague Manfred Green just came in. I'm going to ask him to introduce himself. He's the program director, and here, go ahead. Just say hello.
Hi, I've just come in. I sound as shocked as you are. I'm not quite sure why I'm here, but my name is Manfred Green, and I happened to come past this room, and they said there was a movie on, so I've come in to see it.
It's gonna be a surprise.
and just one more thing, and can you see what I'm holding up? This is our program director, the former founding director of the Israeli CDC, and this is his nutritional guidance for the students. Can you see what this is? It's a bag of Israeli Dorito equivalents. Okay. Okay, you guys are on. Let's get started. Okay. Thank you for doing this.
It's our pleasure. We're going to be tag teaming this, by the way, so we're going to be going back and forth depending on the topic a little bit. Richard, you want to handle questions at the end, or how you want to do this?
Yeah. Okay. We'll take questions at the end. Okay.
Okay. Well, Sarah's going to kick things off.
Okay, and I also wanted to say, kind of explain Jim and I's relationship, because we tag team, and he may jump in if I'm talking, and I may jump in if he's talking. We have been working together for, I don't know, 14, 15 years. And at first I got to know him when he was in my class, my epi class. And then I was also at the same time a contractor at public health that he was at that time the assistant health commissioner. And we have been, once he graduated, he got the health commissioner position, and I worked very closely with him during his health commissioner time, and we developed this community health assessment together. It's the first that we have done in Montgomery County on a formal nature, and we met a lot of times together working on this, and we actually enjoyed it. It was fun. So we're going to share our experience with you, because we think that's better than us reading a lot of academic material that you already have. And I wanted to ask you guys a question before I get going. Have you had epi?
Yes, I have.
Okay, so that helps me so I don't have to explain that type of stuff to you. Okay, so first, Jim, was very kind. He put it together an outline of how we're going to go through this. And our first thing is we just wanted to orient you to the difference between a CHA, a CHINA, a CNA, and a lot of that is just nomenclature for different organizations. So we here in Montgomery County call it a CHA, Community Health Assessment. I saw that the resource that you had for your class was the CNA, which is what the CDC provides. I looked through that document. That is a little different from our CHA. Our CHA is more of a community health assessment in the fact that we are looking at the status of the community through data, maps, focus groups, etc. What I could tell from your CNA is that was getting your community ready, strategizing, prioritizing. It was, and it's part of what the CHA is, but maybe just a slightly different focus. The other abbreviation I wanted to mention to you, because we hear it a lot and we could use it, is a PHNA. That's a Community Health Needs Assessment. And that is what our hospitals are required to do by law, and they have to do it every year. And they also have a slightly different focus. Theirs is kind of a combination between a community health assessment and a community health improvement plan. But for public health, those are actually separate documents for us. I also wanted to talk to you, I'm sure Richard has told you some about where we are, so you know what we're talking about. We are going to use Montgomery County as an example. Montgomery County, West Central Ohio. We have cold weather, where it's cold today. The county itself has about 500,000 people, but with the surrounding counties, it's 1.3 million or somewhere around that. Racially, we're about 75% white, 20% African American, and then the rest would be about 2% Hispanic and 3% of everything else. So we are more diverse than Ohio as a whole, but we are less diverse than the country as a whole. And we are talking about, that's our community. I also wanted to talk from an epi point of view. Your community for your health assessment can be very small or big. So as an epidemiologist, I have done many health assessments. This one that we're talking about today is a large one. We don't do those as often, but I've done health assessments on neighborhoods, or I've done health assessments on conditions. So a few years ago, Richard, you may remember this. Remember Madison County?
Yep.
We were approached by a county next door to us to do to figure out what was going on with breast cancer in that community. And the breast cancer had been, the incident had been increasing at an alarming rate, and the hospitals and the public health were all worked up about what was going on with breast cancer in their community. So the politician from that area contacted Wright State, who contacted Richard, and Richard said, well, let me talk to my faculty and see what we can do. And I proposed we basically do a health assessment for breast cancer in Montgomery County. So the whole health assessment was focused on breast cancer. And Madison County liked it. We did a really nice assessment for them. We had a press conference at the end. And it was a good project for all of us to learn from. So that's a different type of assessment, but it has some of the same principles. And I think that's pretty much my introduction, and now I'm going to turn it over to Jim.
Thanks, Sarah. I'm going to talk about now two specific things. One is, why do a community health assessment? And the second part that's very much related is, who are the target audiences and why are they target audiences? A lot of what I'm going to talk about throughout the entire session here, but especially right now, are things that you're probably not going to read about in any of your class resources. A lot of this stuff really, I never really read in books or really gleaned from a lot of different articles. What I'm going to talk about really comes from the perspective of being the leader of public health in a somewhat populated, fairly urban county in the Midwest. And the picture I hope to paint is, when we get done, is that you would understand why it is that we did what we did in this blue book, in this community health assessment. Keep in mind that traditionally what is done in a community health assessment in a lot of communities is a telephone survey gauging perspectives from individuals that would maybe entail 500 phone calls. We did not think that self-reported information really gave us enough information for our community. So we were fully committed to put forth all of the resources to make this a large project, and it was a large project. I cannot tell you how long it took us.
A long time.
But if I said, between 2 and 3 years, that's probably in the ballpark. Okay.
Right.
This wasn't a 3-month project. This took us a very long time. Why is it that we wanted to do things differently? Number one, we were becoming one of the most data-driven governmental organizations in this part of the state. And we found out that maybe we were becoming the most data-driven maybe in the entire state of Ohio. And we think that those data are extremely important to educate everyone and to help us with decision making. And you'll see that when I go through these target audiences. Number two is we wanted to do this for transparency. We wanted to show all of the information, and we wanted to educate people, not just throw the information out there and hope that they get it. We wanted to teach them. And I think you'll understand when we get through this. Number three is we wanted to build trust that would then lead to establishing relationships. Our big focus overall as an organization was to build relationships in the community. Because if you do not have those relationships in the community, then a lot of what you're trying to do will fall on deaf ears and you will not make progress. So for us, it was all about serving the greater good. This wasn't about Sara and I getting gold stars for a really nice project and everyone else who helped. It was about serving the 540,000 people in Montgomery County. I always considered those 540,000 people my bosses because I got paid with taxpayers' dollars. So I felt totally committed to all of those people in Montgomery County, and that's how I tried to live my day as the health commissioner. The last thing I want to say from an overall standpoint is that I truly believe that all of us as individuals and all of us as organizations need to write our stories every day. We each have a story to write, and I was fascinated by your introductions that you all have really, really interesting stories that you are writing because of where you came from and where you are today. And I always considered this community health assessment that we conducted as being the foundation for our organization's story, because it contains so much information. Okay, so that's kind of the overall for why we did the community health assessment. So now I want to go through these target audiences. I will try to go through them fairly quickly because we do have a lot to talk about. I listed, I believe, 7 target audiences. There are many, many more, but these are the ones that came to my mind. Number one are all of the citizens. I mentioned there's 540,000 of them. Okay, there is a wide range of education and capabilities when you talk about a community. We were basically targeting everyone from middle school age through MDs and PhDs. Think about how big of a range that is of people that you're trying to reach. But we wanted to educate as many people as possible on the health of the county. So it is difficult to reach such a wide range, but when we start talking about the book itself, hopefully you will understand how we reached, at least we attempted to reach everyone. So citizens is the number one target audience. The second audience I've got listed is the public health staff and the Board of Health. Our organization was the third largest health department in the state of Ohio. At its peak, we had 400 employees. We had 70 different programs that we conducted. And I reported to a 9-member Board of Health. They were all appointed, they were not elected, and they come from a variety of backgrounds. Some were health related, many were not. So that's another group that we had to educate. But it was important to educate the staff. We had 70 programs. Many of the staff were pretty focused on their own little program, and they really didn't understand all of the things that the health department did, and they certainly didn't understand all the health-related information that went into all of those programs. So we needed to try to reach all 400 people and show them how they fit into the big picture. And we did that through community health assessment. I also needed to show the Board of Health members why it was that we wanted to embark upon certain things. We had a strategic planning process that followed this community health assessment. Because once you have the data then you can begin to strategize on what it is that you need to do to improve the health of the community. The third sector are all those in healthcare. So all of the folks who work in Montgomery County who either work in the hospitals or in different clinical settings, who are also focused on what they are doing, but they really don't understand the big picture in the county on what it is that's killing people in the county, where the biggest challenges are. Okay, so the other thing that does is then that provides that transparency for you to establish relationships with all of those in healthcare, which is not an easy thing to do. They have their priorities, may not be the priority that you have as a public health department. However, if you show them the data, then they begin to see the picture that you're really trying to do the same thing. The outcome goals are really very much similar. The fourth audience are local government officials. I need to explain to you a little bit about our funding at public health. We were a $40 million organization, and $20 million of the 40 or 50% came from a property tax. So everyone who either owned a residential property or a commercial property paid the property tax, and some of that money went to public health and all other human services in Montgomery County. So you basically competed for that property tax dollar. The community health assessment, what it did was it put facts on why it was that we wanted to do certain things and why we needed the funding from the local government to do those things.
Jim, I'm going to interrupt you for just a sec. Can you move your microphone just a little closer?
Let's speed up a little.
Yeah.
Is that better?
We'll tell you. Go ahead.
Okay. All right. Do I need to repeat anything?
No, I think a couple of things got chopped out, but I think people can figure it out.
Okay.
Right? Do you want to hear about the property tax again, anybody? Okay, well, okay, go ahead.
Property tax usually puts people to sleep unless you're paying it or unless you're receiving some of it. Okay. And it is extremely important for all the human services in Montgomery County. And that's another reason why we wanted to do the community health assessments. Next group are community groups and nonprofits. Okay, we want those groups to be partners of ours. So we need to be transparent with them, and we need to show the data. They were also very, very grateful to get the data because, as you probably know, one of the first things that you need to do before, when you write a grant application, is that you need to show justification for why it is that you are seeking the funds for a certain project. So all of the nonprofits grabbed onto our community health assessment very quickly, and they were actually very appreciative that we put all of the data together. It actually helped us somewhat because what nonprofits do is they would call us on almost a daily basis asking for the data. So we basically put it all in one document, and they had easy access to that. State and federal officials is the next group. Likewise, you are, as local health departments, you are able to get both state and federal special grants. And the only way that you can do that to show that there's a special need. Also, if you do a good job on your community health assessment, that will begin to get you reputation, not only at the state level, but also the federal level. We received a couple grants in a couple areas that I forget exactly what the specific areas were. But I am convinced that the real reason we got it was the performance that we did on the community health assessment. I think the federal government saw if they had the ability to put together the document that we did, then they would probably have the capability, the resources, and the commitment to go through with any sort of grant. So I believe that we actually made some money through some grants at the federal and the state level. There's only two more. One is academia. It's really important for us to make sure that the folks not only here at Wright State, but the other local universities had access to our community health assessment. It is important for us to educate the students, and it's also important for them to see who we are, what we do, because they are our potential future employees of ours. So we wanted them to understand that we were not only a committed organization, but we performed at a high level. And we would hope that the students coming out of particularly Wright State's Master's Public Health Program would view us as a possible place where they would want to start and maybe even end their career. The last group is an extremely important group, and that's the media. I always felt as though the media were partners of ours. That is not a perspective shared by a lot of local government officials. They view the media at times as enemies because they oftentimes are critical of those organizations. I took another approach and tried to get the media as being partners of ours because I knew they could educate the citizens of Montgomery County a lot faster and maybe even more efficiently than I could. If we had something that we needed to get out to the citizens, if the media picked up on it, our citizens would be informed the very next day. If we tried to inform the citizens of a certain piece of information, it could take us months to be able to put together a strategy and execute that strategy to educate the people. So the media was the last group. So I hope you didn't find that boring, but truly those were all the audiences, the main audiences of our community health assessment, and they were all extremely important and part of the reason why we went through the effort that we did. So the next part, I will take a break, bring Sara back, and she's going to give you more perspective on how do you do it? Not the target audiences, but how do you actually put this thing together?
Okay, so I reflected on this, how you do it, for a while, because I could lecture to you for hours and hours on how to do a health assessment, but we don't have that amount of time here. So I decided to kind of talk about the things you should consider and the steps you might be taking in order to decide how to do this. Because they're just like there are a million recipes for chocolate chip cookies, there are a million ways you can do a health assessment. And not one is the best way to do it. It depends on what your goals are for your community. So that's probably the first thing you have to decide on this journey of doing a community health assessment. what is your objective? When I did the Madison County Breast Cancer Project, the objective was to figure out what was going on with the rising incidence of breast cancer in that community. And that helped us move forward in how we were going to do it. When we were talking about Montgomery County, we've already kind of told you a few reasons. Jim explained why we decided to do it. We wanted to tell the story of health in Montgomery County for our community. And that's how we went about it. And he told you about our different audiences. So we had a wide range of audiences. So then the challenge is to do something that is meaningful for all of those audiences. And so the other reason you might be doing it, and there are other reasons besides this, is accreditation. So when we did our health assessment, our first one, accreditation was not on our radar. However, when we started, after Jim left, or actually right before you left, we started our second community health assessment. And about midway through that assessment, the Public Health Accrediting Board and the Ohio Department of Health decided that Ohio Department of Health decided all public health departments in Ohio had to be accredited by the year 2020. And this is accreditation for public health departments is relatively new. I don't know if you have anything like that where you are, but it was all brand new to us when it popped out, and we're the only state that requires that. So now, although we are working on the third health assessment for Montgomery County right now, the objective is still to tell our story. We also have an accrediting board who has requirements for our health assessments, and some of them are very specific. There's still a lot of leeway in how you do it, but for example, you have to have qualitative data for your health assessment, which was not a requirement for us when we first did our health assessment. So if you have an accrediting body, which we do now, the first step is to go through all those pieces and make sure that when you organize it, it's going to include everything that the accrediting board needs to accredit your health department. So after you figure out why you're doing it, one of the big things you have to do is you have to reflect and you have to strategize. So you have to reflect on the level of the health assessment that you're going to do, how big, how small. You have to reflect on how you're going to do it. So who do you have involved on your team? When we started our project, we decided for the most part that we were going to do it internally within public health and get input from external community members. So Jim and I sat down, and actually Jim came to me. We had a one-on-one conversation when we started it, and he sat me down in his office and said, "Sarah, can you do this health assessment for me?" And we talked about what he wanted, and I said, "Yes, I can do it, but I can't do it alone because there are too many skill sets and too much that needs to have different eyes and perspectives on it to do a good job on it." So Jim and I sat down and started reflecting on who needed to be on our team. And there are some key people that need to be on your team. Probably the most important person is the political figurehead for that organization. If they're not on board on doing this health assessment, it's not going to happen because it takes a lot of time, it takes a lot of research or resources, it takes efforts from all sorts of employees, and it needs to meet the goals of that organization. So Jim, fortunately, was already on board when we decided to do this because he had come to me. And then the second thing we had to say was, well, what skills do we have in this health department to make this happen? And we decided to start off that the most important skills that we needed to get going were the health commissioner and the assistant health commissioner, because this was going to be a document that represented our community and that was going to be publicized at all sorts of community events, organizations, to all the audiences that Jim spoke of earlier. So we had those two people involved. Then we had to have data people. At the time, we had 4 epidemiologists. I was a PhD epidemiologist, and then we had 3 other epidemiologists that worked at public health. They were all involved. However, it was myself and 1 full-time epidemiologist that were the main writers and analyzers of data. And there is a reason you have only a couple of main people. Right now, I know public health is doing their 3rd assessment. I'm no longer at public health, but I'm very closely connected to them, and I'm still talk to the epidemiologists on a weekly basis. They split it into 4, and all 4 of them did sections of their health assessment, and they've completed that, and they've reviewed it, and it's coming from 4 different voices. So the whole document is kind of choppy because there's different styles of writing, there's different ways of analyzing data, and it's going to take a lot of their time now to smooth it. So you want to be as inclusive as possible, but you don't want to have too many people involved in the analysis. You need to have a small, close working group that get along. You can involve external people. We have in some smaller assessments included data people from other organizations that could bring a different piece to an assessment that we didn't have locally or at our health department. But when we started out, it was the first health assessment that had been done for Montgomery County at this level. And we started out with the epidemiologists, the health commissioners, and then there's another very important group that I often think gets overlooked. It's the public information officers, the communications people. Because I can make Excel graphs and figures any way, shape, or form you want to do them. But my expertise is not in making it beautiful and making it in a way that people will want to look at those pages. I'm a data person and I can drown you in data, but you need people to actually have it communicated to them in a way that they will read it. So we had our public information officer and his assistant as part of our core team. And how, then one of the other things you need to think about is what's your timeline? So I think when Jim came to me and started it, we wanted to get it out in around 6 months or so. Well, we soon realized that wasn't happening. And I think it was roughly a year and a half when it was almost ready to go.
Just seemed like 2.5.
And it went out the door. You need to think about so do you have the people that are on your team that can make a meaningful contribution to it? Do you have resources? Because it does cost money to do this community assessment. So there are the obvious, printing a health assessment costs. We did a very nice book, and I think our first printing, it was $20 a book, which is very expensive if you're printing thousands of copies of books. So we had that assessment. Then you also have the people resource. So if myself and one of the full-time EPIs are working on this primarily, we're not doing the epidemiology at the health department. So how is that going to be covered, and how are we going to manage all of that? So that's what we kind of decided to get going. We also have for the EPI people, we had a small group of outside individuals that were data people. We had one from University of Dayton and our FCSC, which stands for Family, Children, and First Council. We had somebody from alcohol, drugs, and mental health services. We have a few key data people that we work with in the community, and we use those as a resource to vet ideas and to get input on our analyses and products. So then once you've gone through that, you've got to decide how are you going to do it, what's going to be in your what's going to be in your book. And that could be many things. We had primary and secondary data. We had maps of those, but we did not have qualitative data. The next two versions have qualitative data because we added accreditation, and accreditation requires qualitative data. And then we went, and if you're an epidemiologist, we get data requests every day from the community, from all the stakeholders that Jim mentioned. We get an email request on a certain type of data. So as an epidemiologist, you have a good sense of what are the main topics everyone's interested in. There are lists of them out there now that you can go find. The CDC and accrediting boards will have main topics. But remember, when we were doing it, nobody else was doing this. Or if they were doing it, it was a survey of which was similar to the BRFSS, the Behavior Risk Factor Surveillance System. So we were doing something that nobody else had done yet. So we decided what was our primary data. We had a lot of primary data with regards to STDs, infectious disease. Secondary data, we had our own sources that we could get from the state. We had all the birth data, all the death data, all the cancer data, but we wanted to give an overall picture. So we decided that, unlike many assessments at the time, instead of having one primary source, we were going to use everything that was meaningful to us that we could get on a county level. So we ended up having over 20 different secondary data sources in our community health assessment. And some of those could be food security data. We had the mental health data, which we didn't collect. We had hospital utilization data from the hospitals. We had youth risk behavior data. We pulled from as many sources as we could find good data for. And you have to use your epi skills in this. What's good data? You want to make sure that the data you use is going to be externally valid so that that the community respects it and believes it. If you don't have good data and you publish data that is not meaningful, then people aren't going to use your health assessment. So at that point, we had talked through all those items, and then the first step that I did is we had come up with all the categories that we wanted to include in our health assessment. Chronic diseases, STDs, maternal and child health. There was a long list. And the first thing that I did is I sat down and I spent about a week or two figuring out what was going to be in each section of our chart. And that was, I'll let Jim walk through that with you in a few minutes. He's planning to do that. But once we had that established, then it was a plan of, okay, let's tackle these. The two EPIs sat down and we divided up who was doing what, and we started working on sections. And every time we finished a section, we would send it off to be edited. And editing, I cannot tell you how important editing is. So I can do the data and I can tell people what I think is important out of the data, but then you need editors to make sure that it is meaningful to the reader, that it makes sense to them, that they can understand it. And you have to have editing on a whole lot of different levels. So we had the data editors, the community members, the other EPIs at our health department We had the health department editors. So we had the health commissioner and the assistant health commissioner editing, and people that understood the data better than most. We had those people editing. We had people at the health department that were clerical staff or had very little knowledge to make sure that they understood what that was being read. And then we would send it out to community partners and get feedback on was it meaningful for them. So I can't tell you how long editing takes, but it takes much longer than writing the actual section. And then there's a lot of compromises that have to be made, and you might have to revamp based on some of the comments you get from people. But that's a big chunk of the time. And that was kind of that's the main process. And the devil's though in the details. There are so much that goes into it. And the very last thing that happened was we made it pretty. So our public information officers, one of them specialized in marketing, and he is excellent at taking health data and making it palatable to the public and to the stakeholders in our community. And if you looked at ours online, it's a very pretty document. It's much prettier than most documents I've seen. Okay, so now I'm going to turn it back over to Jim.
Thanks, Sarah. We're starting to wind down here a little bit, but I want to go over 2 items. The first one is how do you present the information? Sarah talked about that a little bit. I want to get into that just briefly, and then I want to walk through it a little bit and explain how we laid it out. I want you to keep in mind some things I've already talked about. The first one is all of the different audiences. You know, I mentioned that we had our community health assessment being used in middle schools in Montgomery County. So that probably includes an age range of what, 11 to 13 years old.
Yep.
We also had MDs and PhDs who were very, very interested in our community health assessment. So we had to try to present the information that appealed to everyone and at least gave most of those folks the ability to understand it. That's very difficult to do. The second thing is we wanted it to be informative, but we also wanted it to be interesting and or pretty. We want people to want to read it, not shy away from it. A third item was consistency, and we're going to talk about that consistency a little bit. So what I'd like to do is, I'm not walking through the whole book by any means, but I want to go through a little bit of it so that you understand why we did what we did. So what do you have there? Do you have a couple paper pages, 18 and 19 maybe, and do you have anything on the screen? What do you have there, Richard?
Everyone has a paper copy of pages 18 and 19.
Okay.
And then they have a geo map of the number of infant deaths by zip code.
Okay, okay. So before you get to pages 18 and 19, let me explain just a couple things that we had prior to that in the book. One is, was a letter from me to the community on what it is that we were trying to accomplish. We also had some information in there on how to read the book. Again, this wide range of audience that we had to assume that they didn't understand some things. So we actually had a glossary of terms there with a lot of definitions so that people had the ability, if they were going through the book and they stumbled across the term they didn't understand, they could revert back to the front of the book and they would get then a description of what that term means. We also had our major calls to action. That term calls to action is going to come up several times. But we had some major calls to action. Most of those were related to healthy lifestyles. because a lot of the focus in the book was on what are the leading causes of death and what could our citizens do to prevent those leading causes of death or delay those leading causes of death. And in Montgomery County, which is the same probably everywhere, the two leading causes of death far and away are cardiovascular disease and cancer. So what could our citizens do to at least delay the onset of those two diseases? More information in there on that as well. But if you could pull out pages 18 and 19, let me explain to you how we laid this out. It may be obvious, it may not. Okay, if you go to page 18 and 19, first of all, I want you to understand that in the upper left-hand corner, in the green box, you will see overall health. Think of that as a chapter. Next to it is physical health status. Think of that as a section. So each section, each and every section, is devoted 2 pages. We were very intentional that we wanted those 2 pages to be across from each other so that you could look at the section and all the information on that section were on 2 pages in front of you. You did not have to turn the page. Okay? I know you don't have it in front of you, but the next 2 pages is the same chapter, overall health, but those next 2 pages is mental health status. Okay? And again, 2 pages then are devoted to mental health status. Going back to pages 18 and 19, physical health status. The layouts were basically founded upon the figures. So if you look at figure 2, you will see that the chart is there, but then underneath it is what is called key survey findings. Okay? That was extremely important to us because we did not want to assume that someone could look at that chart, again, here it's figure 2, and understand what is important from figure 2. Now, the reader might find something additionally important, but the epidemiologists had certain ideas on what they wanted to show, and those are then captured in the key survey findings. Every figure in the book has key survey findings either next to it, above it, or beside it. So we did that throughout the report. For example, if you go to figure 3 on page 19, to the right of that, you will see key survey findings. Okay? So again, think figure, key survey findings, and then each section, so somewhere on the 2 pages, there is going to be a box that is titled Public Health Importance. We wanted people to understand why it is that that information is even worthwhile. So again, for each section, there is a Public Health Important box. So then the 4th item that is consistent with every section, so every 2 pages, is what's listed or on page 19 down in the lower right-hand corner across the nation. We are always asked in Montgomery County, how do we compare to the rest of Ohio and how do we compare to the country? So that box then shows that comparison. So again, for each section, there's 2 pages. There are figures with key survey findings, with public health importance, and across the nation. So those 4 elements would appear on every 2 pages. We believe doing that and doing that consistently will help us reach middle school students through those with advanced degrees. What's that?
So I was going to add, there's one other figure in there. It says overall health status among children. most data that you find for your community is for adults. Because if you want to gather data from children, it's often HIPAA protected in the US and might require an IRB to get data. So there's not as many children's sources. But what we tried to do in every section, if there was children data available for that topic, we included that. But we didn't have children data for every section.
Okay, now I'm going to turn it over to Sara, and she is going to talk about the appendix 9 on page 74.
Okay, so that's the map. When we started doing this health assessment, maps were relatively new. I mean, people had seen maps, but they were just getting to the epidemiologists in a community in a way that we could use them easily. They were kind of clunky and hard to do before that. And now there are so many packages that you can do maps with that I know all MPH students get exposed to it in some way, shape, or fashion. So, but when we started doing it, we decided maps were important because we are a big community, and all of Montgomery County is not the same. There are inequities and disparities by geography that illustrate, and our stakeholders want those illustrated. If you have a nonprofit working in the west part of Dayton, they want the data specifically to West Dayton to emphasize in their graphs or in their grants why they need money for this particular geography. So we decided whenever we could, we were going to include maps. So if you look at this data, this map here, you can see the red is the worst outcome, and it goes down at different colors mean different levels of outcome. But you will see that there was a lot of that map that is not colored. It's kind of that grayish brown color. Either there was no deaths or the number of deaths were too small for us to report because it was potentially identifiable data. And so we have all these big gaps. And that was one of the strategic discussions we had on whether to use maps or not. Because what happens when there is missing data for a community? You know, the first community member who is going to contact you is somebody from that missing data. And they are going to say, why wasn't my community included in your map? So that was a discussion. We didn't want to upset people by not including their communities, but a lot of our constituents of our population really wanted map and zip code level data for us. Now, I think it's a requirement. Everybody does maps. We have better data at smaller jurisdictions, and they're usually not as empty as these maps are. But it did bite us in the butt a little bit when we presented it. People were upset that all the community was not represented in these maps. But we think we made the best decision because we did have data for some of those communities, and we wanted to share whatever data we did have.
The last thing I think we want to talk about is once you get the report done, then what do you do with it? It was really important to us that we took the report to the people, didn't sit back and just hope that people came to us. So we did two things to start. One is we printed, I really do forget the exact number that we started with, but it was probably somewhere between 500 to 2,000 of these books. Okay. I mean, it is 80 pages long, and Sara mentioned, I think that we were somewhere around $20 a book starting out, so you can go through the math on that. So we started with 500, but we wanted to actually send and report to as many of the community leaders as we could. We actually did and printed an executive summary. I'm not sure, I want to say it was probably about a half a dozen pages long. And we sent that, and again, I forget what the number is there, but I'm going to guess between 1,000 and 2,000 of those that we sent out under a cover letter from me. And I was actually asking them to join me as being a deputized public health person in Montgomery County who I did not intend to pay. So Richard, you'll get a kick out of that, right? So I was asking people to join us and be a public health worker without pay, because again, we were talking mostly about healthy lifestyles. We wanted people to exercise. We wanted them to eat right. We wanted them to cut back on alcohol and tobacco. And as community leaders, they could help make that happen. They could actually work with their human relations departments in their organizations and do some things to help people lead healthier lifestyles. So we sent that executive summary out to all of the leaders. And then we had, again, somewhere between 500 to 1,000 of those blue books printed. Eventually, we had to reprint the books twice. We ended up with 3 printings of that book because they were in such demand. And again, I don't know exactly how many we ended up printing.
1,000.
It was probably between 2,000 and 3,000 of the blue books. We began to get those at a reduced price per book, thank goodness. But it was well worthwhile. I can remember the State Department of Health, the health director calling me up saying that he personally wanted as many of those blue books that we could part with. The federal government wanted some of what it eventually became known as the Blue Book. The federal government wanted the Blue Book. It was kind of a hot ticket, and we actually had to strategize on how we were going to hand these books out. The next part was, in addition to that distribution, was presentation. I then began to talk wherever people wanted me to talk in the community. I did a lot of luncheons, ate a lot of turkey sandwiches with green beans, did the evening circuit, did the morning circuit, did the TV shows, did the whole bit. You know, because it's one thing to go through the work, put the book together, develop a nice looking book, very informative book, but you need to take it to the people. They need to understand. And I can tell you that in addition to our response to H1N1, Richard, this book was probably the most popular, significant thing the health department did during my 7 years as health commissioner. And again, thinking back to those target audiences, it was extremely important what we did. It was part of our story, and it helped us get local money. The next time the Human Services organization doled out their money, it helped us get state grants and then federal grants as well. And now I believe it's kind of an expectation. As Sara said, the next book then was put out a little over 4 years ago, and now they're working, or they just really put out a book that was in conjunction, I think, with all of the hospital associations in this part of the state. So I'm sure that's a little bit different now. We were fortunate in that we didn't have requirements to meet that first time around. We did it the way that we wanted to do it, and I can't say enough about Sara and all of the other team members who put it together. It was a team effort. And as she said, it was actually fun to put together. And it was probably one of my proudest moments as health commissioner when we released the thing.
One overall thing I don't think I mentioned is when you're doing this, you want to keep it as simple as possible. Data people, that's a skill. Data people like to make complicated figures and graphs. You always have to remember your audience though, and keep it as simple as possible so that everyone can understand it. And that is really important for your book, your health assessment.
I think that's it.
Okay, first of all, thank you all very much. And let me see if there are questions. It's the end of the day here for them. They've been in school all day. So the biggest question is probably about dinner. But let's see if people have questions. Anybody? I have something I'd like to ask you. In public health, disparities are always a serious issue. We commit ourselves to trying to reduce disparities. One of the ways we do it is by studying and getting data on disparities. But then you have to, in order to affect change, you have to present that information to the communities, both the communities that are on top and the communities that are on the bottom. How did the communities receive the disparity information? I mean, I'm looking in Dayton, much of the disparity is white-black, it's racial. In Israel, it's ethnic and religious. So can you talk about how it was received and how you presented it to those communities?
First of all, it was mixed on how it was received. It's always a difficult thing when you are talking about differences, and you're correct in that the major differences are racial in Montgomery County. But even the maps in the back, when we would show the maps and it would show certain communities, for example, the one location, it appeared as though that their diabetes rate was higher than everybody else's. The city manager of that location, they don't want that, out for everyone to see. But you just really have to explain, what it is. And then oftentimes I think it's important for you to have the right people delivering the message. And, we were fortunate in that we had African Americans on the Board of Health who were willing to go with us at times to talk to groups about certain disparities. And as painful as it is, and it's really disturbing for everyone. But that is the first step. You have to educate people on what the disparity is, and then you have to persevere because correcting those disparities is not going to happen overnight. It's not going to happen within a month, within a year, or maybe even within years. It's going to take a really long time. So you just have to be persistent on your education, persevere, and I believe you have to be as honest and transparent as possible, no matter how painful it is.
But thank you. Yeah, Sarah?
I was just going to add that one topic that I specialize in is infant mortality. So I've given a lot of presentations on infant mortality and the disparities to the community. And I had one time I presented it. I think, Jim, you were there. But after the racial disparity, the deaths are 3 times higher roughly for African American babies versus white. And the time I was presenting it, it wasn't as mainstream knowledge as it is today. And a woman in the audience, African American woman, was sitting about the 2nd or 3rd row. She was crying during my presentation. And I could see her crying while I was talking. And after the presentation, she came up to me that I had no idea the babies in my community were dying at this rate. So what can I do? And so we had this dialogue, and it turns out this woman was a researcher at Wright State and felt in an institute that they had that I had never participated in. But she actually, what we ended up doing was writing a grant, on a communications grant on infant mortality in our community. And that resulted from bringing up the disparity data at that, which was very painful for her. And that is just, and I've had many experiences like that where somebody did not realize that their community was impacted the way it was. And it is very, you have to be very cognizant of how people are going to receive this information.
Let me add to that a little bit, Richard. You know, I talked early on today about transparency and building relationships and basically earning the trust of the community. And that is so critically important in everything that we do. And I do believe that the organization has the trust of the community. And when you present information to them, even if it's really, really painful and embarrassing, at least they believe you and they don't think that you're trying to do something for biased reasons. So again, I just can't emphasize enough in focusing on serving the greater good and being transparent and serving every day with integrity, because sooner or later people are going to understand, you know, what you're about, and when they begin to trust you, then the door's wide open for you to accomplish some very, very special things.
Just an observation to the two of you and also to the students. One of our emphases in our program is global health. And even though the United States is troubled in many, many ways, I think one of our successes is that we do provide a lot, we collect a lot of data and we provide that data back to our communities. And so we measure disparity in the United States. There are many countries that don't. I'm pretty sure Israel's pretty good at looking at disparities and measuring them. But there are countries, I think in France, for example, they'll say, we treat everyone the same. So we're not going to attempt to look at differences. The forms where data is collected won't ask for religion or race because that's believed to not be appropriate. And if you don't collect the data, you're never going to know. Okay. And the United States, I think, is very good at identifying disparities. How we treat them is a separate issue, but at least identifying them gives you the opportunity to try to make a difference. Okay, now I'm just going to see if there are any other questions. Anybody? From anybody? No? Okay. I think maybe we're done here. This is really important, though, because this is the real work, the real work of public health. And incidentally, again, just to the students, you've seen two leaders, okay, work together because they couldn't have done it themselves. You've seen two leaders work together, one doing a lot of the data analysis and collection, that would be Sara's effort, and then Jim, who decided on resource allocation, first of all, okay? And Jim, I'm going to have just one more quick question for you on that. But so here's the leader. He's decided this is a priority. And as a consequence of that, he is allocating resources. And then one of the biggest resources he allocates is himself, right? So he's going out in the community after all this is collected. And we're all familiar with situations where data gets collected, the report's made, and no one ever sees it. Well, why do it? Okay. And so he, as the leader, has decided this is important enough that he is going to eat his turkey sandwiches and green beans, okay? And he's going to go morning, day, and night to get the public to really understand what this is about, okay? This is leadership, okay? So Jim, one more question for you. Did you have a budget for this? And how did the budget correlate to the actual costs?
I don't recall. That's a really good question. I wish I knew, but I do know this. Whatever that budget was, we blew it apart.
Yeah.
For very, very good reasons. And there was did not hesitate a bit. And I got full support from not only the staff, you know, obviously a lot of health departments could not do what we did because they did not have the Sara Patons and the other epidemiologists, good editors. I mean, the health commissioner is a dynamite editor. and the public relations people to pull it together. But we also had the support of the Board of Health, and we also had the support of the people at the county who actually gave us money. So we were pretty tight with our money. You want to say that? We ran our organization like a business, not like a government entity, and we had some extra money. So if we put in there that it was going to be $100,000, I'm going to guess it was probably 300 at the end. But as Sara mentioned, some of it was hard to measure because you're paying people to do things, and they were just having to double down and work extra hard because this was probably their number one priority, but they also had to do all their other work too.
Yeah.
And as you mentioned, I don't know how many hours I was working back then, and it wasn't about me or the hours, but I mean, you just do what you need to do to get it done. But we did have some extra money in all the printing and all the postage and all of that stuff. But in the end, I'm sure that we brought in more money from our efforts with this than what we spent. But far more important to that, I think, is the goodwill that we earned in the community by the efforts from that first Blue Book. I have no doubt whatsoever that was probably when you talk about writing a story, that was probably the number one chapter of the book with regard to the organization for the 7 years I was health commissioner.
Great. Okay. Well, as a former program director and center director in Dayton, I have to say I'm just very proud of both of you. Thank you. Thanks for your time with all this. And it's wonderful to see you. It's really cool that you're 5,000 miles away and that we're in real time. And that's just neat. But it would be nice if we could get you both to come here too. That would be in person. That would be good. Okay.
It'd be fun.
All right. Oh, we're going to say goodbye. And again, thank you very much. Okay. Bye-bye.
Good evening.
Okay.
Okay. Are we done?